So next up, I want to help set the tone today with our keynote speaker, Archelle Georgiou. Archelle is a physician, author, and national health expert who's dedicated her career to helping individuals make informed decisions about their health. And she's produced over 1,000 TV segments demystifying healthcare for the public and currently hosts a weekly broadcast called Speak Up for Your Health. We're so excited to host Archelle. One of the things that came up in our workshop is that aging policy and aging meetings should be fun and engaging. And so that's how we knew we needed to call Archelle and have her kick this whole meeting off today. So we're very excited. She's going to bring us tangible tips, real life experiences, and a lens that's both system oriented and deeply human. She's going to help us bring greater mindfulness to the impact of health policy. And she thinks about this and for people not just here in DC, obviously, but across the country. So please join me in welcoming Dr. Archelle Georgiou.
Thanks so much, Archelle. Well, you didn't tell me that part of the assignment was fun, but hopefully it will be interesting and insightful. Good morning, everyone. Thank you so much, Claire, and to the Alliance for inviting me here today. Aging is on the agenda. It's on the agenda here. It's on the agenda everywhere in the country because it should be. It's important. And I don't know about you, but it's becoming more relevant every single day. And as we think about aging, we need to think about all of the ideas that we have about it, the beliefs that we've had, and to begin to question them. And, are they the right beliefs to have? Because those beliefs are what structure our approach and our policies, our investments, our priorities. And so what I'd like to do today is tell you how I've been thinking about aging, a little bit at a personal level, mostly at a national level, and begin to test some of those ideas. You can come up with your own opinions about that, but I'll certainly share them with you. My lens is as a physician, as a journalist, as a long-distance caregiver from my mother. She passed away a year ago, but it was a journey that was a really important one in terms of my being able to have credibility in this conversation. So, not your grandparents aging, a modern lens on growing older. So 60 is the new 40. Let's think about who in this room believes that that is correct. Oh, less than I thought. Okay, so 60 is the new 40. What I'd like to do is I thought, well, is that an accurate statement or not? Anyone who knows me well will know that I'm a little bit of a math data geek, and so I put the math to that statement. And I started with my family because it's all personal. And we have to sort of get away from the headline that America is growing older and life expectancy is increasing to something just more tangible for all of us. So my mom, Tina, was born in 1932. Her life expectancy at that moment, her cohort life expectancy, was a little over 63 years. I was born exactly 30 years later in 1962. My mom was born in 32. I was born in 62. And then my life expectancy was a touch over 10 years longer, 73 and a half years. And my daughter, Athena, was born in 1992, 30 years later, and she got a little bit less than 10 additional years as well. So I can prove to you that mathematically, 60 is the new 40. We have gained 19 and a half years. There we go. It's 19 and a half if you do the math for the data geeks in the room. But if you add a little Botox and a few fillers, you will get to 20. Okay, so there we go with 20. And the important thing about aging that we don't talk about enough is that the longer you live, the longer you live. Once you reach the age of 60, then your life expectancy increases even greater than what it was at birth because you've won a little bit of the age lottery, the genetic age lottery. And so let's look at what the life expectancy was or is at 60 for my family. For my mom, she went from 63.3 years, she gained 16.7 years, all the way up to being having a life expectancy for females born in that year of 80 years old. You can see that for me, I gained 9.5 years. My life expectancy is about 83 years. and my daughter at 84.1 years. But I will point out, as you can see yourself, that the gains that we've made in life expectancy are decreasing. So the advancements that we've had that really bumped up my mom's life expectancy and mine, we're having less innovation and less opportunity to extend life at this point than we have in the past. But what we really need to talk about is that the longer you live, the more disability you are likely to have as well. So let's look at this last slide where I just have the opportunity to see my beautiful family. My mom, and all of this is based on Social Security data and not personal experience. I just want to highlight that. With my mom, her years of life consisted of, statistically, not her reality, 76.4 healthy years and then about 3.6 years of disability. Look at mine. More years of life, healthy life, but an additional 5 years of disability. And Athena, my daughter, all of her added life expectancy that she gains when she gets to the age of 60 are going to get wiped out by disability. And this is a reality that we have to talk about. So this isn't just a concern that I have. It's not just a concern for women, but it is a concern across the nation. The Institute for Health Metrics and Evaluation out of the University of Washington created this data that shows that the years of disability lived for adults is increasing. I pulled the data specifically for US adults over the age of 70, and you can see that from the year 1990, certainly through today, and then onward to 2050, we have significant increase in the years lived with disability, a 20% increase through 2050, a 12% increase is what we are experiencing today. And let's face it, when we talk about aging, we wouldn't be having this conversation if it was just about chronological aging. The reason we're talking about aging and the reason that it matters is that there's disability associated with aging. That is the only reason we are having this discussion. So let's talk about disability. We've done a remarkable job in the world and especially in our country with focusing on extending life. We've seen that data. We haven't done as good a job on focusing on preventing disability. And let me be clear, I'm not just talking about supporting disability. I'm talking about preventing disability. And so when you look at the conditions, can you hear me in the back? Yeah, okay. When we look at the underlying drivers of what's causing disability, the conditions on the slide shouldn't surprise you. Atherosclerotic disease, heart disease, stroke, cognitive impairment, primarily Alzheimer's, diabetes, and kidney disease. But one that you don't hear about very often, but is the leading cause of disability, is musculoskeletal, arthritis, and back pain. No, they are not the leading driver of mortality. That's heart disease. But the leading driver of disability is musculoskeletal disease, along with the others. So how do we prevent these conditions? How do we invest in that? And I will say that I want to take one step back from even the conditions themselves and say that a root cause of every single one of those conditions is obesity. Medicare, Medicaid, some private insurers have some level of coverage for obesity, but it's hardly enough. We absolutely need to broaden our coverage of obesity treatments. And at the risk of having a strong opinion up on this stage and in this bipartisan room, I will say that we absolutely have got to have conversations about covering GLP-1 drugs. There's no question in my mind. I believe that they are the best innovation that has come to public health for decades. And here's why. They can decrease weight by an average of 15 to 20%. An average of 5% of weight loss can help so many musculoskeletal conditions. Between 5 and 10% will decrease back pain, will decrease knee pain. A decrease of weight between 15 and 20% can begin to help individuals backtrack on some of these metabolic conditions. So let's have conversations about how we can afford and to extend obesity treatments to the population. It is probably the best public health intervention we can make. On the previous slide, I should have added cancer as one of the conditions driving disability as well. It is, but I wanted to save it for this slide. And here is why. In addition to cancer being driven, some cancers being driven by obesity, what I want to highlight about cancer is that, we are all aware of the starting age of cancer screening. So it's 40 for the most part for women to screen for breast cancer, 45 for colon cancer, depending on who you talk to, about 50 for men and prostate cancer. We see, but and the upper limits are also stated, and you can see what the numbers are up on the slide. The science just isn't available to give us better data on when do you stop screening in a healthy older population. So we can't make up the science. But here's the problem. In the absence of science, doctors and patients and insurance companies are saying, well, this is the best data we have, so this is where coverage for screening ends. We need to revisit that discussion. We need to individualize cancer screening decisions, because look at President Biden. We all saw this play out in real life when in his early 80s, in May, it was announced that he had stage 4 prostate cancer. That is not supposed to happen that often. And so many individuals, probably so many in this room, thought, was this a conspiracy? Did they hide it? No, they didn't hide it. He got the best quality of care based on the screening guidelines, which is don't screen men over the age of 70. But when you live into your 80s, this is what happens. That was preventable disability. We need to think about that, the impact of that on a population basis. The second point I'd like to make is that disability will occur. No matter how good we are at preventing it, it will occur. So how do we better support it? And in an earlier convening by the Alliance, one of the takeaways was to balance autonomy. And then I think the rest of the statement was, but putting in place preventable risk and cost, balancing preventable risk and cost is tricky. All of that is true. I'd like to reframe that just a little bit. And I would say that we absolutely have to balance autonomy and dignity for the individual. Nothing is more important. But at the very same time, we also have to balance autonomy and dignity for the caregiver. It is not a one-person decision who decides how it's all going to go and then affect the entire community around them. So those can be tough conversations. I've had them myself. And I believe that some of that gap of what the needs of the individual are, the needs of the caregiver are, can be bridged by leveraging some simple, scalable, affordable technology. So many of them out there. I'm not promoting anything in particular. I will just tell you a story of what we used in our family. My mother was 93 when she died, but from the age of 89, she was becoming increasingly more frail and, like so many others, wanted to age in place. Totally over-romanticized benefits to aging in place. That is another discussion that we can debate. However, yeah, I know I'm not going to go there. I'm not going to go there. But I will say that initially, when it was clear to me and my siblings that she needed much more support, she insisted on staying in place. We compromised with some simple technology. I used Blink cameras, $19.99 from Amazon, put 4 in her house, put them strategically in place. So for $80, we saved thousands of dollars. I'm going to tell you 2 quick examples. One was that I could see her on the cameras, and when she wasn't answering her phone, I was thinking, where's mom and what's going on? And she was awake, but she clearly was not managing in her home. She was sitting, she was playing with her hands in a way that was very unusual for her, and not moving for hours. I called my brother, who lives locally. She went to urgent care, and she had a life-threatening sodium level of life-threatening sodium level that would have caused seizures and then eventually a worse outcome. She was quickly treated, and so even my siblings agreed that I saved her life. We won't talk about my siblings either. So there you go. But maybe the more interesting example is that one day my brother showed up and my mother had like a bruise and blood on her arm, and she had neglected to tell us that she had fallen, and she didn't want to tell us the details because she was afraid of how we would react. Well, normally we would have said she had a stroke, she had a heart attack, she might have hit her head, we need to take her to the ER, they're going to do a CAT scan and an EKG, and thousands of dollars. I actually calculated what it would have cost. It would have probably been a $7,000 ER visit. But I quickly looked at the video screenshots on my phone. It took me 5 minutes just to locate the time. She had a very gentle fall. She was making her bed. She slipped. She fell. She did not hurt her head. She was up within 7 minutes, which I also saw in the videos. And it completely gave us peace of mind that she was safe. She didn't hit her head, et cetera. So I've gotten some reactions like, are you spying on her? Does it feel like Big Brother? Technology like this can give you peace of mind as the caregiver while allowing the individual to maintain their autonomy, their dignity, their independence at home. So these types of solutions we need to talk about more broadly. And I do believe that it's also important that we get over the stigma of palliative care and even hospice. But let's talk about palliative care. Such a coordinated, beautiful, loving, supportive approach to care that's covered, that's available, that is completely underutilized because of the stigma. Let's get over it. Let's support it. Let's promote it, because palliative care increases quality of life, increases patient and caregiver satisfaction, and decreases utilization. Okay. So there's the Elon Musks and the Peter Attias in the world, and they invest in and believe, along with all of the other Silicon Valley bros, that aging is inevitable. I will tell you that as of today, it's not inevitable. Maybe in the future, but it's not today. And that is because aging is influenced by 3 things. 2 of the 3 are not, we can't change. So time, just chronological time, puts wear and tear on your cells. Of that constant regeneration, your cells will die. Just like if you take perfect care of your car engine at about 200,000 miles, it's going to die. Same thing with your body. Assumed upper limit of life for a human is about 121 years. At least that's what the scientists are saying. No matter, even if you're completely disease-free, just because of the turnover of cells. So can't change time. Genes, if you are lucky enough to be in a family that's had longevity, then again, you've won a little bit of the genetic lottery and you're going to live longer, but you can't change your genes. But I will tell you that there is one thing that you can and we can as a society influence, and that's the environment that your genes are in. That is referred to as an epigenetic clock. So, how do you slow down the epigenetic clock? Well, there's 3 things that either make it increase in its rate and make you age faster, or slow down and you can slow down aging. And that is your microbiome, primarily the bacteria in your gut. That's most of where our microbiome is. Your lifestyle and inflammation. So for your microbiome, it has been shown scientifically that the Mediterranean diet, low meat, fruits and vegetables, you've heard a lot about what that consists of, actually decreases what's called the DNA methylation on cells. It decreases the rate of aging, Mediterranean diet. Exercise does something similar, and I had to put smoking on this slide, which probably affects the DNA methylation, but it would have been irresponsible as a physician to not have smoking on this slide. So increase in exercise, decrease in smoking, and then inflammation, chronic inflammation that can be caused by so many things, including stress and then the lack of socialization or purpose. And so, of course, the converse is true. If we can increase socialization and purpose, we can affect DNA methylation as well. A lifestyle that includes all of these things, doesn't that sound idyllic? Sort of is. So many of you have probably heard of the blue zones. They are places in the world where people purportedly live the longest, with many centenarians. One of them is Ikaria, Greece. I was on the National Geographic expedition in 2009 where we explored Ikaria and the secrets of longevity of the population there. I've been back many times and came back from Ikaria just 2 weeks ago. Certainly many things have changed from the mid-1900s, early 2000s when many of this data was collected. However, it is still a very remarkable environment, one where even as recently as 2 weeks ago, people eat what they grow, with the exception of salt, sugar, flour, and maybe they import the yogurt from Athens. But everything is they eat what they grow. It's rugged terrain, so you're naturally walking. But maybe what's most moving is to see the interaction between all different ages in the socialization. And then the shopkeepers are, they're both young and they're old. And so many individuals. This lady truly was the first person we saw when we were on our drive to our hotel who was just walking down the street doing her chores. I was just ready to just pick her up because she looked a little frail, but she was doing what she needed to do. So the suggestion here, and from a policy advocacy standpoint, is certainly not to bring Ikaria to us. There are many other disadvantages to living in that environment, and I am glad to be back home. However, I do think that it highlights a few things. One is that we need to be listening to these movements that have a good data behind them on food as medicine. The American Heart Association did a synthesis of all of the randomized controlled trials that look at the effects of food as medicine, and then as well looked at many of the observational studies, and clearly supports that we give access to patients to healthy food as part of their health care. Not that healthy food is good for health, but healthy food is an important part of someone's health care. The same is true of exercise as medicine, and I know that there are many great organizations, including those based here in DC, that are promoting the same and promoting prescriptions for exercise as part of a treatment plan. And then finally, I will say my most controversial statement, which is to eliminate retirement. Please don't be my friend. You cannot be my friend if you ask me when I'm going to retire, because that word is not in my vocabulary. I want to be really clear about what I mean by this. Do I mean having anything to do with Social Security? Absolutely not. I'm not qualified to have opinions about that, but I will tell you that I am separating out the concept of the word retirement from financial benefits that occur after the age of 67 for somebody who's in my age group. So why do we use this word retirement? Why do we ask people when they are going to stop adding value to society? When do we put pressure on them to become less valued members of society? First of all, it's not even accurate. According to Pew Research, currently, over 20% of individuals over the age of 65 are still working, 9% over the age of 75. And I know I'm over time, but I'm going to give you one more quick anecdote, which is that my husband is a gastroenterologist. He's 74 years old. He married young. And he is thinking of his whole life transition. He has no interest in being on call anymore. But on September 15th, he's asked, when is he going to retire all the time? He's not retiring. He's starting a new role, full-time associate professor at Yale as a gastroenterologist at the age of 74. And that may not be right for everyone, but let's stop asking people about when they're going to retire. Clearly, it has economic benefits. And it also has social benefits to an individual's sense of their own purpose and value. And it decreases the stigma of someone who could feel and be treated like they are a burden to society. This is my last slide. I always do like to stick with the data. This is again from the Institute for Health Metrics and Evaluation. They did a scenario prediction of what it would look like if we changed lifestyle behaviors and metabolic risk factors, and how we could bend that curve on years lived with disability. And look at that dotted line going down below. We have the opportunity to bend that curve by focusing on disability. And no, it's not going to take till 2050. I calculated from their data the impact that we could have just through 2030, just 5 years from now. We could save 3.4 million years lived with disability by just making some changes. And that's something that I, as a grandmother, would love to see. So thank you so much.